in the chat. And I will also apologize for my voice because I am just coming over a cold. As a health reporter, we should all know it's respiratory virus season, and there are many viruses out there. So I'd like to welcome everyone to this really important discussion, and we're going to be hearing from some really amazing experts today about a very important topic. We know that adverse outcomes, safety issues, deaths for people who are pregnant, people who are giving birth, remain an issue around the world. And really, even in places like Canada and in particular the US. So these are really important discussions to be having, and I'm so pleased to be leading this discussion today. I'd like to acknowledge, first off, I'm speaking to you from the traditional lands of the Adirondack and the Haudenosaunee. Again, for anyone who does need interpretation instructions or IT support, please look to the chat for those discussions. Right now, in order to set the stage for our discussion and lead us off into some of the main points that we're going to be speaking about, I'm pleased to introduce Fred Chabot, who's Acting Executive Director for Action for Sexual Health and Rights. Please take the stage, Fred.
Thank you so much, Carly. Thank you, everyone, for joining us today for what will no doubt be an incredible discussion on reproductive justice. I was counting the days for today. This is really exciting to have everyone in the room. So thank you for joining us. Reproductive justice is human rights plus social justice, or the lived realities of those whose rights we're talking about. And so what makes the timing of this conversation particularly interesting is that right now we're at a sliding door moment for both human rights and social justice globally and in our country as well. In the last years, there's been pivotal moments that can and will shape the world we will live in. These moments come with both opportunities and challenges. In 2020, a global pandemic was declared, and states' response to it have forever reshaped politics in countries, but also on the global stage. In 2020, we also saw the rise of Black Lives Matter as a movement after the murder of George Floyd, reaching levels unprecedented before. In 2021, the first mass grave from a residential school was confirmed with the help of new technology here in Canada, which leveled up consciousness for many Canadians. In 2023, Gaza. This turned the lights on the hypocrisy of the West when it comes to using the human rights system to its own end. In short, now, like never before, people are looking at the agreements we've made with one another. This attention is important, and we need to take advantage of it to recommit. This year is the 30th anniversary of the Cairo Platform of Action, 30 years since the countries of the world came together and said yes to coming together to invest in sexual and reproductive health, because it's essential to health, to development, and to prosperity. Right before attending the International Conference on Population and Development in Cairo, where the entire world agreed that the individual rights to plan your own family must be central to global development, a group of Black women gathered in Chicago. They recognized that the women's rights movement, led by and representing middle-class and wealthy white women, could not defend the needs of women of color and other marginalized women and trans people. They needed to lead their own national movement to uplift the needs of the most marginalized women, families, and communities. And reproductive justice was born. The ICPD Plus 30 anniversary, which we're about to celebrate, provides a unique moment to take in today's world and recommit to our collective commitment to these principles at a moment where human rights are being challenged as a concept. As we recommit, it must be to bring the meaning and the dream of everyone living a good life, one of freedom and peace, to the center of it. This milestone is a call to action not only to invest and push for the provision of health services because people have a right to them, but to address the system that exclude and marginalize communities from fully realizing those rights. The ICPD agenda, grounded in the principles of human rights, equality, and dignity, is as relevant today, if not more, as it was 3 decades ago, as we see those global challenges. As we stand on the brink of this anniversary, it is imperative to acknowledge the progress we've made and equally the challenges that persist. We are so honored as Action Canada to be connected to and have the chance to convene such a powerful group of experts, advocates, and practitioners to grapple with these essential questions today. Thank you all so much for tuning in, and we hope the discussion provokes some important thinking on the wide range of interventions and issues that require our attention as supporters of sexual and reproductive health. It's now my pleasure to introduce virtual remarks by Minister Ahmed Hussein, Minister of International Development of Canada, before we turn to our speakers. Thank you so much.
Thank you, Action Canada, for hosting this important event. While most maternal deaths are entirely preventable today, around the world, almost 800 women die a day from complications related to pregnancy and childbirth. Because all too often, women and girls are forced to turn to service providers who are not trained or who don't work in safe environments. In fact, research from UNFPA shows that maternal mortality has actually risen in the Americas by about 15% since 2016. And women of African descent are notably overrepresented. Both in Canada and around the world, we know that racism, inequality, and discrimination are still barriers to accessing healthcare. And the government is committed to supporting culturally appropriate, safe, equitable, and inclusive healthcare for all Canadians through the work we do at home and abroad. As you know, this year marks the 30th anniversary of the International Conference on Population and Development. This milestone gives us an opportunity to review the work that's been done globally on sexual, reproductive health and rights, take stock of our progress, and determine how we can work together to ensure equitable access to SRHR for all. Because no woman, no matter who they are or where they are, should have to fear for their life while bringing a child into the world, especially when the knowledge to treat these common complications exist. And with help from those of you on the front lines, we will continue to raise our voices to overcome discrimination, inequality, and racism in healthcare. Together, we will ensure comprehensive SRHR services reach those who need it the most. Thank you for everything that you do.
Thank you so much to the Minister for making those remarks. And I believe that unless Fred needs to come back, I'm going to now introduce our panel. Great. So I'm going to be introducing our panel and leading off the discussion for today. I'll be introducing everyone, but first we're going to be hearing from Patricia. So Patricia De Silva is the Program Advisor with the UNFPA, which is the United Nations Sexual and Reproductive Health Agency. We will also be hearing later on from Alini Dr. Executive Director of Planned Parenthood Toronto, Anna Balaganis, co-founder of the National Collaboration for Doula Access, Althea Jones, President of the Association of Ontario Midwives and Executive Director of the Ancestral Hands Midwives. So Patricia, I'd like to first begin with you and just have you sort of set some of the scene and context for this discussion that we're going to be having today.
Thank you. Thank you so much, Carol. It is, first of all, thank you to Action Canada for the opportunity to present this important work on maternal health of women and girls of African descent in the Americas. I also would like to thank Minister Hussein for his opening remarks and Fred for giving us this important global context. This is an issue that is extremely important for us at UNFPA. And of course, I'm honored to be here and be with my fellow panelists to discuss this important issue. I think it will also be important to maybe situate this analysis in the larger context of UNFPA's work. The UNFPA is the United Nations agency that focuses on sexual and reproductive health and rights, and whose objectives is to deliver a world where every pregnancy is wanted, every childbirth is safe, and every young person's potential is fulfilled. And so one important aspect of our work is that we're deeply committed to ensure that we leave no one behind. And we're talking specifically about those populations that historically have been marginalized, of course, including women of African descent, but not only Indigenous peoples and other racialized and marginalized groups, who unfortunately still today are often victims of multiple and intersecting forms of discrimination. So UNFPA has also committed to the 3 transformative results by 2030, 0 preventable maternal deaths, 0 unmet need for family planning, and 0 gender-based violence and harmful practices. So with this in mind, and also responding to the need for the fulfillment of the rights of people of African descent, like Fred very well said at the beginning, in support of the program of activities of the International Decade for People of African Descent that actually ends this year, and of course the ICPD Plan of Action, UNFPA developed this comprehensive institution global strategy for people of African descent. And at the core of the UNFPA strategy for people of African descent really is our desire to counteract racism and racial discrimination as pivotal social and structural determinants of health. And we do that through the design and the implementation of targeted programs, advocacy, enhanced communications. We're also looking to strengthen our partnerships and continue to developing disaggregated data and evidence, like with the study that we're talking about now. So the highest attainable standard of health and medical care, including sexual and reproductive health and maternal care, it is indeed a human right. And regarding maternal health, what we have found recently is that we've seen an aggregated decrease in the global maternal mortality rates. However, the progress has not only been slow, but is also unequal, both between regions, between countries, and also within countries. And this is really apparent, and that is highly concerning for us. So when we look at the global numbers, what we're seeing is that in Europe and in North America, maternal mortality rates raised about 17%, and in Latin America and Caribbean, about 15%. And let's also not forget, because this is important, that about 70% of the world's maternal health deaths are still happening in sub-Saharan Africa. So we really wanted to understand the extent of the impact of these disparities for women and girls of African descent, so we decided to investigate. We brought together a group of partners that had diverse. It was important to have, our partners from the reproductive justice movement, academic institutions, special experts on the issues to have this conversation, to have this analysis done. So we analyzed the data for 9 countries: the US, Uruguay, Trinidad and Tobago, Brazil, Colombia, Suriname, Costa Rica, Cuba, and Panama. And then we explored data for five indicators: maternal mortality, family planning, adolescent pregnancy, access to antenatal care, and access to skilled birth attendants. These indicators, of course, are closely linked to maternal health outcomes, including to maternal mortality, are also part of the SDG indicators around maternal health. Unfortunately, we were unable to include Canada in the study due to the lack of official statistical maternal health data that is disaggregated by race and ethnicity. So what we found in this study is really alarming. Structural racism and sexism, so gendered racism, drives maternal health disparities and is really a key barrier to achieving the highest attainable standard of maternal health. We found also that these disparities actually exist across income levels, across education levels, and national and subnational borders. For example, in the US, Afro-descendant women with a college degree are dying 5.2 times more than their white counterparts, and then 1.6 times more than a white woman with less than a high school degree. In terms of the indicators, the most statistically significant disparities we found in maternal death rates, access to family planning, and adolescent pregnancy. And the latter really is important because adolescent pregnancy is one of the biggest issues that causes deaths for girls between 15 and 19 years old. And again, Afro-descendant girls are overrepresented in this group in the region as well. So let me just give you some more specific statistics. Of the 4 countries with globally comparable data for maternal mortality, US, Suriname, Colombia, and Brazil, women of African descent are dying of preventable, and preventable, the word preventable really is key here, as you all have referred at the beginning, of preventable maternal causes in the US, 3 times more, in Suriname, 2.5 more, and in Brazil and in Colombia, 1.6 times more. Just to be clear that this does not include indigenous peoples. So of course, across the America, there are, in addition to gender racism, there are also other systemic inequalities or other social determinants of health that play an additional compounding role in these outcomes. This includes overrepresentation of people of African descent amongst the poorest, particular women of African descent being overrepresented in informal markets. That leads to a lack of social protections, including universal health coverage, intergenerational poverty, that leads to an overall lack of access to the most basic human needs, including quality health. The data also show to us patterns of abuse and neglect, so obstetric mistreatment in health services delivered, and the persistence of unscientific beliefs in medical education. So, and we found that these manifest themselves in different ways. Women of African descent pregnancy or their childbirth is not monitored as closed. They are more often rejected from hospitals and receive less appropriate or less quality, timely pre and post labor care and newborn care as well. Includes their symptoms frequently being disregarded, their concerns being unheard, their needs being unaddressed. In fact, white women in the US report 15% points lower experience of mistreatment than all the other groups. And of course, this is also important, and this is why we always emphasize the quality of the health that women are receiving. And so just to finish, again, these trends are very concerning. And the specific situation of women of African descent, it is indeed a crisis. It is a crisis that is in need of targeted attention. Thank you.
Patricia, thank you so much for this really important framing of the issues. You know, from a worldwide context, we know that there are so many barriers and inequities that lead to adverse outcomes and preventable deaths. And, you know, it's obviously concerning that here at home in Canada, you know, it's obviously is such a problem that we don't even properly track it. And that lack of data really means that we just simply do not know the extent of the problem. And this is obviously in particular concern when we look at some of the most equity deserving groups, including our Indigenous populations who live in rural and far north remote communities with little access to healthcare providers. We also know that, you know, in the Canadian context, we have, you know, a wider healthcare crisis going on. And so it will be really urgent to look forward and hopefully try and figure out some mechanisms for trying to address and close some of these gaps. We know that structural racism and sexism are evident in compromised maternal health outcomes. This report and these remarks also suggest that there's no racially disaggregated data available for Canada. As we transition to the next presenter, you know, some of the context setting for, you know, what Althea is going to be speaking about, you know, do the trends that we've been hearing about from Patricia and from the UNFPA report match the realities that you've been seeing in your work as a midwife? And what are some of the systemic barriers in Canada that contribute to racial disparities in maternal and reproductive health care? I would like to just, you know, lead off by introducing again Althea and just thinking about those larger questions, you know, the role of community organizations like Ancestral, which Althea, I believe, founded, and the role that you think other healthcare providers need to play in to ensure culturally appropriate interventions. So Althea, if you'd like to begin your presentation now, it's going to be really interesting, and I'm eager to hear what you have to say. Thank you so much.
Thank you. Thank you very much. Yeah, so I can definitely say that the trends in this report do kind of mirror what I see in clinical work. However, I can easily access the American statistics that you see here that illustrate the Black maternal health crisis. As we've already touched on, unfortunately in Canada, we don't collect race-based data, or if we do, it's very fragmented and it's not easy to access. And so this really just illustrates that sometimes racism isn't about what we do, it's about what we do not do, because not collecting this race-based data really hides the disparities and makes it very difficult to access the funding and the resources needed to enact change. But in the very limited Canadian data, like we really do see the same trends. In Canada, Black women and people are overrepresented in the national rates for most significant chronic illnesses such as diabetes, cancer, cardiovascular disease, HIV/AIDS, lupus, and hypertension, and they have earlier onset of these conditions. And in relation to perinatal care specifically, Canadian studies have found significantly higher rates of preterm birth and increased incidence of severe preeclampsia for Black women and people. And so whenever the data is available, the health status of Black women and people is found to be poor, and this really is an impact of racism. Next slide, please. And just to go back in terms of systemic issues, so what are the barriers? I don't have time to go through all of these, and some of them have already been nicely covered. But I'll just start by saying I held a focus group to support my proposal because there wasn't any race-based data that I could use for my program for Ancestral Hands Midwives. I needed to propose this to the Ministry of Health. And so in this focus group, I wanted to ask people about their healthcare experiences. And so, like has already been touched on, bias and discrimination was something that participants brought up. Cultural competence or lack thereof was something that participants also spoke about. And the lack of cultural competence is really rooted in systemic issues. And to give an example, healthcare providers are not taught during their training quite often about how conditions present in Black people. And so this can lead to misdiagnosis, incorrect treatment, misunderstandings and miscommunications, and inadequate support for Black patients. In terms of research, we've already talked about the lack of race-based data, but another point to think about is that Black people are underrepresented in medical research. And so this has huge implications such as ineffective treatment strategies and biased clinical guidelines. And to give an example, during pregnancy, we use growth charts to track people and how they're growing to make sure that their pregnancy is progressing as we would expect. But these growth charts are based on European standards. So often Black women and people don't align with this growth chart, which can lead to increased interventions, often for both the birthing person and the baby, who, when the baby is born, may be deemed as small for gestational age based on these clinical guidelines that really weren't even made with them in mind. In terms of access, I've already talked about the fact that Black women and people have higher rates of chronic illnesses and early on, and this affects their access to midwifery care. And so they're disproportionately ineligible for this care that is high contact and low intervention and can really help improve outcomes, but they can't access it because midwives typically work with low risk normal pregnancies. We've already touched on the socioeconomic factors that are a huge issue and impacts health. And then finally, I'll just talk a little bit about representation. And I'm not just talking about the lack of Black healthcare providers. I'm also talking about the lack of Black representation in the spaces where policies are made, funding decisions are made, how curriculum for our healthcare providers is designed. When you don't have Black folks in these spaces, you miss representing that community and making things that work for them. So simply put, our Black people are not in a healthcare system that was made for them. Next slide, please. And so I think organizations like mine, Ancestral Hands Midwives, can definitely be part of the solution. And I call it AHM for short. And it's a Black-focused prenatal and postpartum midwifery program that focuses on access, education, and empowerment to improve Black maternal health. And this program really involves a collaborative model of care, which enables even high-risk clients to access midwifery care. And this is important due to what we spoke about earlier, where Black clients are disproportionately not eligible for this care. And our program really involves midwife-led care, where midwives offer supportive care to high-risk clients while sharing care with an obstetrician, and also providing care to clients that were unable to access midwifery care. And then the postpartum care really involves both the birther and the baby. Midwives take care of both people until 6 weeks postpartum, and this takes place both in the community and clinic or hospital settings. And being able to offer this care to more people really fills a big gap that happens in postpartum care. And really, this is not just a gap for the Black community, but for the whole perinatal community. And our program really values culturally congruent care, and we've worked really hard to create culturally relevant educational content, such as the Birthing While Black prenatal class, which is an online course that really covers a lot of the same topics that typical prenatal classes cover. But it also speaks to things like advocacy and how to speak up for yourself in clinical settings and topics that are really relevant to the Black community. And this course is completely free, and we're looking forward to adding in-person classes and workshops. And the goal of Ancestral Hands is really to create an environment that enables clients to be better seen, heard, and listened to, while empowering them to make informed decisions and to connect with the resources that they need. And for me, I really don't think there's a secret to better outcomes. I think and experiences, you really just have to listen, explain options, offer needed support, address the social determinants of health, and just provide good care. And I think it's also crucial for us to support the healthcare providers that are doing this work. Next slide, please. And just in terms of what does it mean to support community-led initiatives, like I really think it does, involve funding, but it kind of more importantly, it also means you need to allow these organizations to test things. Accountability does not always mean perfection, so we need to try different things to see what works. And just as the healthcare system was built over time, it will take Black and other underserved communities time to really get it right. And so while some initiatives may be seen as failures, we really need to empower these communities to learn from those failures, which will breed the next iteration of change. And instead of telling organizations that they're not eligible for funding because they don't have certain things in place, help those organizations get those things and build those systems. Involve the Black community and healthcare providers in any implementation and programs that are designed, because far too often the communities are left out of these initiatives. And I'll just to wrap up by saying, we just need to support innovation. Don't accept the status quo, because that's what's brought us here and it's not working for Black communities. And so we really just need to support and allow people to do things differently, try different things, and see what works for their communities. Thank you.
Thank you so much, Althea, for such a really important conversation and providing so much information. I think it's also really important to note that, while there's so many problems and lack of data collection in Canada, it's really inspiring to hear about some of the work that you and others are doing to try and bridge some of those gaps, to try and bring services to the communities that deserve that equitable treatment, and really trying to do that work and bridge the gap and do solutions-based work. So that's really great at a time when it's so difficult, for so many to get the treatment and the access to the system. So thank you so much for the work that you do, and thank you for those remarks. We know that a lot of barriers that, are facing so many equity-deserving groups in Canada, the Black community and beyond as well. We're going to turn to Anna in just a moment to have a presentation on some of the work that she's doing in this area. Anna is the co-founder of the National Collaboration for Doula Access and has extensive experience, working to support immigrant and Indigenous communities. So I'm really looking forward to hearing some of what Anna has to say about that experience and the work that is being done there to try and bring better access to those communities, improve outcomes in pregnancy and beyond. And just really thinking about how we're trying to, I think collectively as a whole, pay more attention to the social determinants of health and the impact that they have on these kinds of outcomes. So Anna, I will turn the microphone to you. Take it away.
Thank you so much. Hello, everybody. Thank you for the introduction, Carly, and thank you to Action Canada and UNFPA for having me be a part of this panel today. My name is Anna Balagtas. My pronouns are she, they, and I'm a queer reproductive justice advocate and community organizer. And today I want to talk about why prioritizing the systemically marginalized is reproductive justice. Next slide, please. I'm one of the co-founders of the National Collaboration for Doula Access, and we are a membership-based charitable organization who's dedicated to supporting practicing doulas who belong to and work with Black, Indigenous, and people of the global majority. Another acronym for this is BIPGM, but you may know it as BIPOC. We are a national charity, and our work is committed to the values of anti-racist feminism, decolonial and anti-classist birthwork, 2S LGBTQIA+ inclusion, and restorative justice-based approaches to conflict resolution. At the NCDA, we believe that tackling systemic barriers affecting Black reproductive health outcomes is essential because they affect other systemically marginalized groups as well. Our liberation is completely tied together. And if there are folks in our community that are not accessing the care that they deserve, how can we expect that the rest of us will access the resources that we need to, right? What led us to start the NCDA was being doulas of the global majority ourselves. So there are 4 of us who have co-founded the organization, and we all belong to systemically marginalized communities. Some of us are doulas with experience in immigration and in diaspora, and we see through our lived experiences and through our communities how essential reproductive care access and resources are, and the way support has a wave of beneficial impact, especially when it comes to BIPGM and systemically marginalized communities, which is why our priority lies in supporting these communities themselves. Next slide, please. So alongside my work as a doula, I'm also a community educator within the birthwork space. Something that I like to mention in my teachings is that reproductive justice isn't just about babies. In the framework of reproductive justice, there are 4 pillars. One is the right to bodily autonomy. The next is the right to have children, the right not to have children, and the last is the right to exist in a safe and supported community and environment. There's a really big misconception that reproductive justice will only focus on all things reproduction, and reproduction can only mean babies. But the truth is that your whole life is a reproductive transition. From childhood through gender identity and exploration, through immigration, and even through death. Reproductive justice isn't just about the reproduction, isn't just about children. It's also about the right to exist in a safe and supported community, which is the pillar that we often forget when we think about reproductive justice. As well, when we think about the pillars, we have to ask ourselves these questions. What does it actually mean to have the right to have children when we live in a racist and fat-phobic medical industrial complex? What does it mean to have the right not to have children when we live in a corrupt, colonial, cisgendered, white, heterosexual patriarchy? What does it mean to have the right to bodily autonomy when disabled folks are constantly left out of the conversation? And what does it mean to have the right to parent in a safe and supported community when we systemically underserve Indigenous, Black, and people of the global majority in Western societies? When we ask these questions, when it comes to the pillars of RJ, we can clearly see that there are different systems and factors in play when it comes to reproductive justice, and it's not always just about children. We have to remember that reproductive justice is for everyone, and our fight for justices under these systems of oppression is tied together. Next slide, please. One of the questions we were asked to ponder on when it came to our panel today is why we should consider a social and political analysis when it comes to healthcare policies. I deeply believe that we can't build healthcare policies without factoring in different intersections of systems that affect the folks who will be accessing the care. Social and political structures play such an important role in the ways folks, specifically marginalized folks, access resources around their community. So let's take, for example, reproductive care services for Indigenous birthing folks in the Northwest Territories. How are we to build healthcare policies without first understanding the reason why Indigenous birthing folks are displaced when needing to access birthing services in the first place? One of our co-founders of the NCDA, Sabrina Flack, is also the co-founder of the Northern Birthwork Collective, and their mission is to make sure folks in the North access the reproductive care services they deserve, though the infrastructure in the territories is severely lacking. And these services are not up to par because the government hasn't prioritized the need to build structures for folks up north, because Indigenous folks have been historically displaced even in their own communities. These are both social and political structures at play for Indigenous birthing people. So when it comes to building healthcare policies for folks up north, we have to factor in the other intersections of systems that affect them. Otherwise, we'll only be building policies that tell half the story, and it may not even benefit those that it targets to the full extent. So in order for Canada to implement policies well, I believe that we have to listen to the voices of the systemically marginalized, and we have to follow our lead. We can't make assumptions on what folks need, and instead we need to invest our time, our money, our resources, and especially our support to let the communities lead their own initiatives that they know will benefit them best. And that is me. Thank you so much, folks, for witnessing me and for your time.
Thank you so much, Anna. Really important conversation, and again, really, I think inspiring to hear about some of the ways, the innovative ways that people like you are rising to the occasion to tackle these long-standing challenges, and just kind of providing that context for how we're addressing some of these really big, thorny, difficult questions, right? And trying to, I think that's one of the reasons why having discussions like this today are so important, is really trying to elevate those conversations and ensure that even it's speaking about them and raising awareness of the work that's being done on those local levels to serve these communities is helping to make the situation better for everyone and can help us lead to better outcomes. So thank you so much for the work that you've been doing, and looking forward to chatting more with the rest of the panel. I'm now going to transition to talk with Mohini about the work at Planned Parenthood Toronto and some of the, the ways that you're tackling some of these big questions. I think, oftentimes we hear about Planned Parenthood, certainly in the media, in the context of, some really contentious and thorny issues around access and pregnancy and birthing. And we know that these are obviously vital services that are provided. I feel as though oftentimes we don't necessarily understand the full scope of the work that Planned Parenthood does, and sort of the different ways in which you're supporting people in pregnancy and birth and beyond, to support all aspects of sexual health and more. And again, kind of bringing it back to that with the lens on equity and trying to help populations who have nowhere to turn, perhaps, but Planned Parenthood. So I'm looking forward to hearing some of the highlights of some of the work that you've been doing, some of the challenges that are being presented, and how we're working toward tackling some of those, looking at this through sort of an equity lens, and trying to bring better services and improve outcomes for racialized populations and beyond. So I will turn the stage to you, Mohini. Please feel free to take it away.
Thank you so much, Carly. I do have some slides. I guess I want to start with saying I feel very lucky to go after all of these amazing speakers who have done the important context setting that is actually crucial to any discussion around race and healthcare and medical racism. So I'm going to really lean into that privilege of it going last and gloss over some things, but refer to them because they're actually the crux of this conversation. So I'm going to talk to you here as the Executive Director of Planned Parenthood Toronto, which is unique when it comes to the Planned Parenthoods in that each one is different, but in Canada, they're not quite exactly what they are in the US. PPT is a youth community health center, and I'll be diving into a little bit of our response to medical racism and this report that we that hopefully is a backgrounder for most folks. So next slide, please. So Planned Parenthood Toronto is located in an area that was a region that was an important gathering place known as Tekaronto, which is a Haudenosaunee word. And the meaning of this word is where the trees stand in the water. And Toronto it exists on top of a living network of sacred waterways, and we now refer to it as the Big Smoke. And the reason I want to situate us there is because that is important context setting when we talk about the city and we talk about geography, we talk about environmental racism, we talk about the displacement and genocide of Indigenous people, we talk about a legacy of transatlantic slave trade from the continent of Africa. These are like living legacies in the city, and that is really important when we think about our place as folks in the healthcare system, particularly if we are not Black or Indigenous ourselves, and trying to respond to this. I did put in a suggested reading that I think is really important framing that talks about this globally and the response of communities and individuals to this ongoing crisis that especially people of color are responding to, with all of these intersecting historical and ongoing oppressions. So I just wanted to put that there. Next slide, please. So a little bit of context setting, important for Planned Parenthood Toronto. We're a community health center. We serve youth 13 to 29, and we're unique in that we're only one of 3 community health centers in Toronto that have a citywide mandate. So we don't just serve a particular region of the city. We are supposed to serve the entire city. We provide comprehensive primary care, community programs, and service navigation. That's characteristic of what a CHC does. We have a sexual and reproductive health focus, both being a Planned Parenthood and also because we recognize that as an important entry point for a lot of young folks to engage with primary care, and just important to young people's whole bodies and honoring the whole self. And I want to highlight that Planned Parenthoods have a racist, eugenic, and feminist history that is really important for us to understand, contend with, hold in both hands as we also, seek to do anti-racist work or seek to repair with communities. And for that, there's lots of writing. There's a book called The Trouble with White Women that has a whole chapter on it that I encourage you to read. Planned Parenthood Toronto has a mandate to center racialized and 2S LGBTQIA youth, and that since 2022 and our new strategic plan, we are moving intentionally from a choice-based reproductive rights frame to a reproductive justice frame. And I know that that was already mentioned. I think Fred talked about it, and I know that it was touched upon later about reproductive rights being too narrow a focus, really centering white middle-class women and not meeting the needs of Black, Indigenous, and racialized folks. So next slide, please. Okay, so I wanted to share this map of Toronto. This data is very difficult to get. We've talked about this already. I've been looking at municipal data that gives us some clues, and the information repeats itself, and it reinforces everything that we've been talking about here. So these are the City of Toronto's own designated neighborhood improvement areas. They indicate the outcomes of inequity in a number of neighborhoods that continue to experience marginalization and deep inequity. So you'll see that the 2 regions are in the northwest and the southeast of the city, and Planned Parenthood, just for folks who are not familiar with the city, is located kind of at the bottom middle, quite far away from these 2 orange patches. And that itself tells a story. Why these neighborhoods are designated as improvement areas or experiencing high marginalization is absolutely linked to everything that Althea and Anna and everyone else on this panel has been talking about. So that's where I'm going to gloss over it, but it is essentially the social and structural determinants of health and deep racism. Moving on, please. Next slide. I wanted to pull out one in measure of inequity, which is rates of teen pregnancy. And they also, as you can see, map on to those so-called neighborhood improvement areas or high rates of marginalization. And these are, as you might have guessed, areas that have high numbers of the communities are mostly racialized, mostly Black, and South Asian. As the City of Toronto is known as one of the most diverse in the world, it is also one of the most highly inequitable in the world. And these patterns just keep replicating themselves. So there's many maps like this that you can access. And no matter what inequity you kind of look at, when you look at the geography of Toronto, it just keeps replicating itself. So whether it's teen pregnancy, whether it's high rates of teen STI, someone mentioned small for gestational age infants, whether it's food deserts, all of those things just continue to replicate themselves. So I'm just going to move next slide, please. And I wanted to just also show that when it comes to access to primary care, that's my focus. It really shows the high levels of inequity in Toronto. If you look at 3 key areas, so Midwest Toronto, where we are, Northwest Toronto, and Southeast, you can see that under the age of 35, 3.8% of white folks are unattached to primary care, with 69.8% of racialized folks are unattached. In the Northwest, 3.6 versus 80.2. Southeast 2.1 versus 87.2. So that really also paints a picture. Next slide, please. This is a conclusion of one of the chapters of Inflamed, where basically the conclusion after all of this is listen to Black women. And it is because, yes, data is important and we're missing that data, but those stories that we hear are actually everything. And those stories are relational, and they reveal where and how inequity shows up throughout the healthcare system and societally at large. So we could dive into each one of these, but I think that, the statistic at the top that says in the US, Black infants die at a rate of 3 times higher in the hands of white physicians than Black physicians is paints a very important picture. And as organizations who are mainstream organizations like Planned Parenthood, how do we build and repair relationships with Black communities? How do we move forward in the work that we need to do, whether or not we get the funding? It's important to maintain an anti-racist frame at the core of everything that we do. And I also want to say, and I heard someone else say this already, I think it was Althea, that perfect sometimes is the enemy of the good, that our discomfort potentially of being not Black and trying to do anti-racist work or anti-Black racism work can often stymie us or keep us circling, and that's not good enough. That we have to keep moving and building those relationships, and that challenging the narrow arrogance of Western biomedicine is crucial. It is crucial because Western biomedicine is also built on the decimation of Black and racialized bodies, Indigenous bodies, and the decimation of knowledge and the stealing of knowledge. And that we know that medical schools are built to reinforce this kind of racism and misogyny. And that is leading, as we saw in this report, to very, very serious outcomes, including ill health and death. So I think I have run out of time. I could talk about this forever, but I'm going to just stop there. Thank you.
Mohini, thank you so much. This is a really important piece of the conversation. So thank you for sharing that. It's going to be, I think, a really interesting year in coming years looking at these kinds of questions as we do focus on them more and more. And I think with a lot of unfortunate developments in countries like the United States, it's given us an opportunity to reflect even more on the kinds of inequities that we're continuing to see in places like Canada in 2024 and beyond. And, sort of looking at more of, beyond just a national lens, also to the international lens, casting ahead, looking to the International Conference on Population and Development. In just a couple of months, I believe it will be the 30th year anniversary of the Cairo Declaration, really kind of setting the stage in, sexual reproductive health and rights, putting it at center stage. And it will be a really good opportunity to kind of look back at where we've come and how far we have yet to go. And how we kind of look to some of those gaps and bridging them. So I'd like to welcome Patricia back right now just to speak about some of what we are going to be focused on in the months and years ahead, what we need to do to bridge some of those gaps, how governments and other organizations can improve the availability and quality of disaggregated data. Patricia.
Thank you. Thank you, Carol, again, for bringing me in. And I just want to say that I'm always in awe when I have these conversations with the work that is being done out there by so many amazing organizations and amazing people. So thank you for all the work that all my fellow panelists are doing out there. So the analysis really made many recommendations. I encourage everyone to go and read the report. That we made recommendations for governments, for international organizations, for the health system, the education system, et cetera. A lot of them have already been referred here by some of the other panelists already, but I can maybe highlight some of them. So we talked about, addressing the structural determinants of health that are faced by women of African descent in accessing healthcare system, of course, including gendered racism. But also, I think starting with at a more systematic level, implementing systems of respect for maternity care approach, reproductive justice frameworks, the life cycle approach that was already discussed here in detail. We also recommend fostering inclusive policy design and decision making. So I think Althea mentioned that, including people of African descent, indigenous peoples, in the conversations that are looking to design these policies so that their inputs and their lived experiences are part of these solutions. And also, of course, increasing Afro-descendant representation in the healthcare force, including, of course, amongst midwives and doulas, etc. One of the things that we found in the study is that actually countries that have a well-developed midwifery system, including from the communities and within the communities, have actually much better maternal health outcomes. So that's really something that we want to amplify and to scale up as a response to this. Of course, adopting a primary health care, universal health coverage model of care, with a focus on equitable, culturally appropriate, and competent maternal health care. That's also an important recommendation. Reforming the medical education is really unacceptable. That things like, Black people's bloods, coagulates faster and we don't feel as much pain are still part of believed as scientific truth. So we really need to look at that as well. And then complications related to pregnancy and childbirth really are one of the leading causes for adolescent deaths between age 15 and 19. And Latin America has the second highest rate of adolescent pregnancy. And it was really interesting to listen to Moshini talk about also the adolescent pregnancy rate, the rates of pregnancy in Canada. So really addressing these two intentionally, it is also can play a critical role in decreasing maternal mortality for women of African descent. In terms of the data, that's really an important question. I like the concept, data is key, but it's not king, indeed. Completely agree with that. We do need the data, but we also need the stories. We need the lived experiences. We need to understand what is being done that is working by many of us out there and really scale up those experiences and those efforts. But we looked at the lack of data actually also as a data point itself. Like not having data is also telling us a story of systemic racism, of course. So we need to continue to advocate for more availability of disaggregated data, including administrative data, administrative health data. It is really hard to fix what we cannot see. Data helps us contextualize and understand the needs of those population groups within their realities, within their contexts. Black people, indigenous peoples, not homogeneous groups. What is reality for a Black woman in Chocó, Colombia is not the same reality in Rio in Brazil or in the Bronx in New York. And just some quick data points that I think would be interesting is that only 11 out of 35 countries in Latin America collect maternal health data broken by race and ethnicity. Only 9 countries had comparable data, maternal health data, and only 4 countries had comparable maternal mortality disaggregated by race, ethnicity. So any policy plan program that looks to improve and bridge these gaps really needs to also, amongst all the things that we talked about, really include this important issue of the availability of the data disaggregated by race and ethnicity. Thank you.
Thank you so much, Patricia. Really important to have your voice alongside everyone else today to talk about these really important issues. So thank you so much for your time and being with us here today. I'd like to now just quickly turn to the rest of our panel to just to ask everyone the same question and have all of you weigh in before we have time for maybe 1 or 2 questions from the wider audience. And the question is coming from the report, which is linked. If you go into the Q&A in the answered questions, there's a link to the report for those of you who are asking. The overall recommendation of the report is governments, international organizations, and healthcare providers in the region can meet the maternal and sexual and reproductive health needs of Afro-descended women and girls by addressing the root causes of structural racism, sexism, and discrimination. So in just 2 to 3 sentences each, I'm wondering what your recommendation is for action that needs to be taken to close these gaps and make pregnancy and birth safe for all. Perhaps Patricia, if you're able to stay with us and answer that, and then we can move to the rest of the group.
Sure. I just, in terms of the data, I just wanted to add an important point that, of course, the data needs to be collected, analyzed, and disseminated with a do no harm approach, with the full and meaningful participation of the populations that are affected by this work. That's an important point. And I think in terms of your question, I mean, that has been answered by, I think, by all of us. We need to work on this collectively together, bring our experiences to the table and work together. We need to critically reflect on our work, on our programs, and ask ourselves intentionally, what are we doing to ensure that we're not leaving anyone behind? What steps, specific intentional steps, have we taken to address root causes of inequality in maternal health, including, of course, racism and sexism? So I'll invite you to join us in this journey. Join ICPD 30 in a couple of months, our journey to zero preventable maternal health, and particularly our journey to really bridge the gap for racialized groups, to marginalized groups, including women of African descent and Indigenous women. Thank you.
Thank you so much for that. Mohini, perhaps you could answer that next.
Yeah, and I might just answer a question that I accidentally deleted because I think it's related, but asking about how we are, what we're seeing, those visual maps and that data, which is very important for us to understand who we are underserving, how that is impacting PPT. So, without any, we are in a moment of privatization of healthcare across Canada and in this province. So without any increase in actual funding, where the response that we know we must have is to build relationships with organizations that have expertise in Black maternal or Black reproductive health, and which we have been doing. So one of the things I want to say, and this is unfunded, but it's just 3 organizations determined to meet this moment. So it's a gender-based violence shelter, it's another community health center up in the Northwest, just to name them, Blackfeet Community Health Center, and Planned Parenthood Toronto, figuring out how to build relationships, build trust also, and listen into what community needs and bring services up to an area that we can see from our own data. Very few clients come to PPT, even though clearly there is need for services up there. So it's slow relational work, but it has to be done. And again, it might not be perfect, but it has to be done.
Thank you so much. Althea, I'll turn that question to you now.
I definitely agree with what's already been said, and so I won't repeat that. I'll say support midwifery, support midwives, allow them to access the community and provide the services they want. There's a lot of restrictions on how we practice and where we practice and when we practice, and what we can and can't do. And it's not a matter of scope creep, like we only want to do what we're qualified to do, but there are just so many aspects of the medical system that we could help in, but we're not able to because of policies. So that's what I'll say.
Thank you. And Anna.
Thank you, Althea. Yes, I definitely agree with you. Supporting midwives is key. They're so essential in this work. I also will say that we've mentioned it before, communities, we all don't need the same thing. Our needs for access, our needs for resources, they're so different based on our lived experiences and where we are in our communities. So I will have to say we have to follow the initiatives of the folks who are underserved themselves, because we know what we need, and we just need the support, the resources, the financial basis really to create the change that we know we can have for ourselves. But we need that support from folks. We don't need folks to assume what we need. We know it.
Thank you so much for that. We have only about 2 minutes left in this discussion. We have a couple of questions in the chat, and then we'll probably just have to end it there. There's one question that I don't think we've addressed yet, and that was for Mohini, but anyone who wants to weigh in obviously also can. And that was about what kind of listening center for patients there are for those who desired in pregnancy. Just asking about specific ones in Toronto and beyond, or healthcare organizations that can listen to people's concerns. So if that's something that you or others want to address, that would be great.
I don't know what's meant by a listening center. I will say that at PPT, we support folks' choice across whatever their choices are around their pregnancy. There's I think a preconception that abortion is our number one service, and to be honest, we've provided maybe 30 abortions last year. Most of what the vast majority of what we do is primary care access, and including reproductive choice when we'll refer out. But yeah, I think there's lots of listening at most organizations that provide any kind of reproductive and birth services for whatever the choice is for someone that's pregnant.
Thank you for that. And maybe this is a bit of a large question, but I'll end it off here and just we were reflecting a little bit on the privatization creep in Canada. We have a primary care crisis, and just how urgent it is to sort of address the issues that we're having with access to primary care, particularly in a lot of communities that are equity deserving, and how we start to even I guess the urgency around that. Maybe I could just throw that one out to someone like Althea, as in your sort of new role with the Midwives Association in Ontario, sort of how we kind of try to address the ongoing crisis and how we start to bridge those gaps.
Sorry, is the question about privatization and like my response to that?
More or less on sort of, I mean, that is the background context, but just kind of this overall crisis in primary care and how that's spilling over and making it difficult for people to access all care across the spectrum.
We really need to support our healthcare providers and those on the front lines in this system. I think too far removed are we from those who are making decisions based versus those who are actually doing the work. So I think that's the main thing. We know we have an ADHR crisis and that healthcare providers are burning out and leaving the professions, and we really just need to support them and add the resources and show them that they're cared for and appreciated, because oftentimes what we see in government is kind of a slap in the face to those people that have been on the front lines and doing this work. So I think that's the main thing, is really just support.
Thank you so much for that. We're now at 1 o'clock, so we respect, or Eastern time. So respectful of everyone's time and schedule. Just wanted to thank everyone for being here today. Thank you to everyone who organized this and took part out of their day to listen and be part of this really important conversation. And in particular, I will just single out Patricia, Mohini, Althea, and Anna for being here today and sharing your thoughts and expertise on a really important topic. And I look forward to hearing more and reconnecting on this in the future. Thank you, everyone.
Thank you. Thank you for the invitation.
Thank you, Carly. Thank you so much.
It was my pleasure. And